Hi, Christine. Hi, Trevor. Hi, everyone around the world. We've got people from North America, South America, Europe. So it's a really international crowd today. So we're going to talk today about mental health in higher ed and exploring the relevance of UDL from a multidisciplinary perspective. And really so I'll get you going on Menti. It shouldn't say Mentimeter there. It should say just menti.com, the one you already logged onto. So just get ready because we'll use it in the next slide. What I wanted to discuss is the fact that even when we look at the design of instruction and assessment, and even if we are adopting a design perspective and thinking about UDL, when it comes to mental health, we tend to back away. Suddenly, it's what I've noticed in my practice that even the most fervent advocates of UDL are really scared of touching mental health. It's as if when we talk about mental health, we fall back into a medical model. And so I wanted to explore this and have a look at why that is and how can we change that from a multidisciplinary perspective. How can we get people to adhere to this notion of design thinking and UDL, even when we're talking about students' mental health in a classroom. So this is the poll which I'd like you to do, and I'll carry on talking while it's happening, and then in about 2 slides we'll go back and see. So I'd like you to, on this topic that we just discussed, to think about your level of comfort. So on the Menti, you won't see the full questions because they're quite long, but what you need to do is sort of select your level of comfort. So if we start with level 5, which is the optimal level, you're actively using UDL to redesign instruction and assessment to reduce mental health. So you've already thought about it, you're aware of it, you're doing it, your campus is aware of it, and you're actually doing this actively in your classroom. So you're looking at mental health, you're looking at what could be the possible causes within your instruction, your assessment, and then you're using UDL to try and address that. Level 4 would be you feel UDL is explicitly used on your campus to reduce mental health. So not necessarily in respect to you, but you've seen practices. We've just talked about community of practice. Maybe you've got colleagues involved in that work. You have the feeling that on your campus, people are trying to do that. Level 3 level of comfort would be who feels campus are tackling the impact of bad design on student mental health. So here we're just at a very large level of campus awareness, but you feel that there's something there going on in your campus. Level 2 of comfort level would be you feel campuses are aware of the impact of bad design. So they're not doing anything about it, but they are aware that that is one of the causes why we're seeing so many mental health issues on campuses. And level 1, you feel that mental health issues in the classroom are sometimes caused or exacerbated by the design of instruction. So again, choose your level of comfort. 1, you're just aware that there's definitely a causal link there. 5, your campus is doing it and you're actively doing it in your classroom. And then we'll look at a pie chart in a little bit. I just wanted to bring this up as an illustration. This is an article from The Guardian recently. It says 2009, September. The way universities are run is making us ill inside a student mental health crisis. So The Guardian has run a really good series actually over the last 2 years about mental health, looking mostly at faculty first, but now they're getting to the student part. And they're running sort of fairly in-depth article. And they are tackling I think that question that people are feeling a little scared of. We're all talking about this explosion of mental health on our campuses, but to what extent do we actually contribute to this? To what extent is it not just an external phenomenon, but it's something that actually is grown within universities and is grown because of the practices in our teaching, all right? So not just something that's about students, but about the way we actually design our environments. So how did this come about? I'm going to be fairly narrative here. So we had a conference here, the third Pan-Canadian conference on universal design was held here at my university, Royal Roads. And at one point, I met with the director of student services and with a director of instructional designers. And I said, would you be interested in doing a session on mental health and doing it as a 3-party sort of workshop? So we hadn't really thought in depth, but we thought this is a great occasion to get together and actually talk about this from a multidisciplinary perspective. And it went really well. The session was great, was really well attended, and we got so much feedback that I decided to really go with this. And I thought there's really something there, because even within the session, you could see that our perspective as faculty, head of accessibility and instructional design, we didn't have the same perspective at all. And I thought there's really something we need to dig into there to see how that could be the sort of trigger for change on our campuses. There's getting together of perspectives and actually thinking about the way our design influences some of the mental health issues that we're seeing. So it's now a fully fledged research project. I've had a research grant for this, and that's some of the reflection I'm going to share with you today. So maybe this is a good time. I'm going to just stop sharing and just jump onto Menti and see what kind of result we had from Menti. So just let me It takes a minute to change. Let me find Menti, and it's this one. It will take a second to populate. Okay, so one was the first level of comfort, was you were just generally aware that there's a causal link between the way we design things and the mental health issues we see on campus. And you see where 58% of you are thinking that that's the level of comfort you are. Two was, you're starting to think on your campus about what we could do. And three was an awareness around your campus that, we need to do something about it. 4 and 5 were the level of action, right? We're already tackling design and we're moving on to actually looking at how we're designing to reduce the amount of mental health issues that we're seeing among our students. This is very telling, and it's what I see in most sessions when I run this. And it shows really it's a call for action that we have now to go beyond this awareness. We are aware UDL is a great tool. So what can we do with UDL to start tackling the way we design instruction and assessment? So that's what we're going to look at now. Let me just go back to my slides. Any question, Christine, so far?
I think we don't have any questions at the moment, but we definitely are getting a lot of lively discussion here on the comments. I think there was one comment there kind of saying that it's such an important point raising with other practitioners, and that is often met with negative responses, and that there's a major problem with the lack of program review with assessments in particular.
Absolutely. Can you see my slides full screen now? Is it good?
It is, yeah, it just needs to be in presenter view, that's all.
It's not wanting to do it for some reason. Hang
on.
That's
okay, no problem.
Yeah, it might have said this, I don't know. Zoom is doing something weird. It's refusing to let me go on to presenter view.
No problem.
I wanted to touch on the literature. And so before we move on to that, the reason why we're so reticent could be a presentation in itself. I think I've done it in workshop. If we were in Dublin and we had a bit more time, we could have opened that discussion. Why are we so reticent to tackle mental health and actually look at the causes of mental health in terms of design of our environments? There's a lot to look at, and in terms of administrators, in terms of faculty, we have a lot of fears there, and it's something that we need to erode as well. So what does the literature tell us? So there's very little literature on mental health and UDL in higher ed. It's generally absent from UDL literature altogether. I found a few instances where UDL is talked about in terms of CBT, cognitive behavior therapy approaches with youth, and then UDL is tackled within that, but not specifically within a university context and more community work. It is hints that UDL is effective in eroding mental health challenges in terms of design, but it's very conceptual. There's no really any example. So really, we have a great paucity of work here. So I'm also running another call for action in this session to encourage all of you to look at this, because I think it's a new next frontier for us in UDL in terms of scholarship, in terms of research and publications. Every time I run a session like this, people will be emailing me and saying, do you have publications on this? Do you have publications on this? So one will emerge from this, but I encourage you all to contribute to this, because it's really an area that all of us have to look at collectively. So what I'd like to do now, if we'd been in Dublin, I would have opened up the workshop to really discussing all of these three perspectives that I'm looking at within research. So the perspective of faculty, perspective of accessibility, disability services, and the perspective of instructional designers. In Dublin, I would have asked you to really get in those shoes and really think within that, with that hat on, and think about what's the perspective that these practitioners have on mental health within their campus and in terms of UDL. So we're going to do it in a more conversational way. We have less time and we can't be fully interactional, but I'll ask you for a minute to place yourself in terms of disability services. So I use accessibility services, that's what we use in North America, but I know in Ireland and other countries it's disability services. Put yourself in those shoes and think about the most frequent complaints, let's say complaints or comments that you're getting from students in terms of what causes mental health issues for them in the classroom. So I'll let you think for a few seconds, and then we'll go through a list that I've already sort of put together as I'm collecting data from disability service providers. So you probably had a minute to think of the first things that come to mind. You'll see if you recognize some of them. So this is a quick compilation, as this is still work in progress for this journal article, but a quick compilation of some of the things that are coming out. There's quite a lot, as you see. It's coming up a lot in those conversations between students and disability service providers. We'll run through it quickly, and you're probably browsing the slide. Time assignments or exams, participation grades, team assignments, assignment deadlines, lack of flexibility in assignment format, tension in relationship with instructor, unnecessary textbook or disproportionate reading list, triggers present in the course content. So here we're talking about triggers in the content themselves without warnings, learning outcomes that are not clear or easy to understand, course schedules that are not clear or easy to understand, course activities that are not accessible or viable for students with mental health issues, content not accessible in itself starts creating frustration, anxiety, and therefore mental health issues, and an over-reliance on leave as a way of addressing mental health. This last one's interesting. This is the frustration students are saying to disability service providers. What they keep telling me is to take leave and go and get better. All right. And sometimes the students have been living with that for a long time and they're saying, I'm not going to get better. So I would like people to stop telling me to take leave, even with empathy, but that's what they're getting. So look at all of these and then think of how many of these we can actually make a difference, how many of those we can tackle with universal design for learning, with design thinking, even generally. So, I'll run with this with you quickly because we can't be fully interactive. Now, there are some that we might not be. It's probably easier to actually look at the ones that are not necessarily by design. Triggers present in the course content, that's actually going to be a wider reflection about, some of the issues, some of the themes that you're bringing to the classroom and the sensitivity that some students may have. But pretty much all of the other 11 are things that you can actually tackle through design. And they are really the results of bad design or teacher-centric design. So this is a really potent thing, right? So we have accessibility, disability services being on the front line and seeing all of these complaints and being able to tangibly quantify how many of these issues actually are related to bad design. And yet, I'm going to leave you some open questions. How often do disability service personnel have time to discuss the design perspective and of these challenges with faculty? Open questions, but I think on most campuses, these are rare opportunities. And why? Because of our silo mentality, because of a lack of bridges that exist in communication, because of etiquette, because it's very difficult for disability services to go and tell a faculty, some of what's happening here is because of the design of your assessment, the design of instruction. What pathways exist for this dialogue to happen? Very few on our campuses. What are some of the obstacles in this relationship? Well, we've seen power dynamics with two different professional bodies that, often campuses don't encourage that kind of difficulties. So in this article, I talk about the two solitudes. In Canada, we like talking about two solitudes when we talk about culture, French and English culture, being two environments in Canada that don't speak to each other. But I think that works really well when we talk about disability services and faculty, that we are literally in these two solitudes. We have this discourse that is filled with frustrations and comes from the fact that we don't actually share our perspectives and have time to discuss that. So very quickly, because I know we're conscious of time, put yourselves now in the position of faculty. I didn't introduce myself because I've already done the keynote and I had a slide on that. But I've been disability service provider and I've been faculty. So switching hats like this is something I do quite often. So I'm encouraging you to do the same. Step into faculty's shoes now and think about the sort of frustrations or the sort of tension that they feel with regards to mental health in a classroom. What is it that they might be reporting to me as a researcher when I'm talking to them about that? So here again is a quick recap of some of the points of tension. Already you're going to see there's a lot less. So we can already deduct that they're a lot less aware of the complexity of design issues that actually creating mental health issue for students. So that's the first observation, really off the page like this, you can see. And then their focus is really based on what they're feeling in the classroom. And what they're feeling in the classroom is very strong tension around these points. So the road to use a role presentation in the classroom as a form of assessment. They're doing this, and what they're reporting to me in qualitative feedback is that they're realizing that this is creating problems, but they don't really know what else to do because they actually think oral presentations are a good thing, and it's creating anxiety and stress and mental health issue. Class participation marks, they realize that that's creating, it's a source of mental health issues, but they're not always clear of why and how. An over-reliance on term paper format, saying, I'm going to have 2 term papers, 3 term papers. They realize it's not ideal. They realize it creates tension for students. But again, they don't necessarily engage beyond that in what else could happen. Arbitrary deadline, they're very aware that when they say this is due on such and such date, it creates problem. Sorry, I'm still at coffee time here. We're still 8 hours behind you. So arbitrary deadlines, they realize there's a lot of tension being created there, but they're not always quite sure, what they could do about that either. And then intrusive requirements for explanations from students and for disclosure. This is when they are being, in the traditional format of accommodations and medical notes and things like this. Something is late, they have to ask the students why, and they have to ask for documentation. They realize that's creating tension and mental health issues, but they're not quite sure what to do either. And at times they realize that accommodations themselves create stress. They're aware, for example, that if they send the students to a disability service center for exams, and they're running the exam in the classroom and they realize there's a mistake in the exams, it may take a long time before they have the foresight to call disability service providers and say, you've got a student sitting an exam somewhere else on campus, there's a mistake in my exam, could you correct that mistake? That they realize is creating huge issue and huge problems with mental health. So again, we see these tensions, we see a sort of emerging feeling that they understand that that's the cause of issues, but what are they doing about it? Not much. And yet, I'll run quickly on this slide, you can see that the process for the faculty would be very simple. A UDL process of reflection around this tension that they're feeling would be common sense, requires no specialist knowledge. It requires no insight into students' diagnostic information. It requires no financial or staffing resources, and it would allow the faculty member to feel re-empowered. So this is all the great things that they could be doing if they were engaging with UDL with respect to these points of tensions that we've just noticed. So on this, I just want to, before we move on to the instructional designer perspective, to put the slide up. I'm not going to address all of these, but I think it's important when we think about faculty that we think that they themselves are also often suffering from mental health issues. And we forget about that when we're not looking for the faculty perspective. And it's important to think of the reasons why they're feeling, and I've put some of them, over workload, mental health, own mental health issues, desire to remain inconspicuous within their department politics, unions. There's all sorts of reasons that are also pressing on them sometimes not to change, not to engage with EDL, not to unpack the problems that they're seeing. I'll give you an example. When I was assistant professor in the 4 years back, for 3 years when I was assistant professors, I taught 49 courses in 3 years. 49, and out of 49, 46 were graduate courses. That's the baptism of fire that most faculty are living. So when we're seeing faculty not responding sometimes, we have to think of why are they themselves exhausted? Now quickly, because I'm conscious of time, what about the instructional design perspective? So quickly slip into those shoes and think about instructional designers on campuses if you are lucky enough to have instructional design and an instructional design center. So I'll sum up some of what I've collected so far. They have obviously a good understanding and mastery of universal design. That is not a problem. They have that resources. But they are rarely called on to seek solutions with regards to barriers experienced by students of mental health. So we've seen that disability service providers are registering this, the teachers, the instructors are feeling it, but the instructors are not being called into this dialogue to actually provide solution. Often their expertise overshadowed by the campus's medical model. So they have the expertise, they have the solutions, but we are still going to go and see a psychiatrist, go and get a medical note, go and leave. We're not doing this sort of triangular correlation between the problem and the causation. They have few organizational opportunities to contact accessibility services. So think about it, they have difficulties, I'm going to come to it, creating bridges of communication with faculty, but they also usually don't talk to student services and disability service providers. So that part of the communication doesn't happen. Often on most campuses, they are unable to trigger contact with faculty unless the faculty trigger contact. So it's left to the faculty to make contact. They are not free to call a prof and say, do you need my expertise with regards to UDL? Often they realize there's strains on faculty's time and availability. They're working on eggshell when it comes to models of instructional design. So sometimes, they fear, I can't really start unpacking all this fully because people are just not wanting to hear about teaching theory and things like this. And then the work is rarely embedded into mission statements. So even if they have that desire to speak up and offer solutions with regards to mental health, often there isn't a wider systemic setting for all this to happen. So that's basically it, and I'd like just to leave you with a few reflections. Obviously, we see it on the simple presentations like this. UDL is relevant to mental health. We've seen the points of tensions. We know what UDL is about. We can see how UDL fits in and would actually resolve most of these tensions that we're seeing. But yet, it's not happening. We know that instruction and assessment design has an impact on the mental health of students. a redesign of assessment instruction can erode mental health issues in the classroom or avoid their exacerbation during the time when the students are with us on campus. And it always also would allow the instructors to put an end to the cultural referral. So what I mean by cultural referral is saying, I don't have an answer for this, someone else has an answer. So disability service providers have an answer, or a psychiatrist has an answer, or someone else has an answer somewhere. It would actually put an end to that and makes instructors with solutions with regards to the tensions that they are feeling. Last, before we go to questions, I know we're running out of time. The point of this whole sort of research paper and this presentation is also to show you that we are coming up with the questions because we're taking the time to stop and take a multidisciplinary approach. We're taking the time to listen to disability service providers, listen to faculty, listen to instructional designers, and then we're seeing easily how the pieces are coming together. But that's an artificial environment that I've created. On most campuses, we're not doing that. And that's really the last call of action of this presentation is, what can we do on each of our campuses to make sure that we start creating this triangular dialogue? Because as you've seen, we have an enormous amount of things to learn from each other. Faculty have things to learn from disability service providers, but disability service providers have something to learn from faculty. And both of these professional sort of stance and positioning have a lot to learn from instructional designers. So let's break the silo mentality. Let's break all these etiquettes on our respective campuses that are preventing those exchanges. And let's think forward of ways that we can create this triangular multidisciplinary perspective and then be able to use UDL to unpack all of these points of tensions that we've seen with regards to mental health and have an authentic dialogue. And the authentic dialogue is to stop saying we have a problem with mental health issues on our campuses and to say we are creating the mental health issues of students, issues of mental health issues with students on our campuses. We have a causal role in this and we can change that and actually reduce the sort of tension that we're seeing and the manifestations of mental health on our campuses. So that's about it. Trevor and Christine, got the references there. You've got 2 PowerPoints. So I've loaded the PowerPoint, which is the full PowerPoint, which I would have used in the workshop live. And then you've got the shorter conversational PowerPoint that we've used today.
Absolutely. Thank you so much, Frederic. That was, gosh, there was so much in that. You could almost take a week.
There's a lot to unpack there, definitely.
Yeah. Frederic, I think, yeah, you need your own radio show, I think, like a 2-hour-long section. But anyway, there was a few interesting questions coming up. There was Chloe Cox and Amy Johnson, both in the chat feature, just mentioned about either over-assessment or the timing of assessments. That kind of typical, like, overburdening of assessments towards the end of a semester is quite common. So again, kind of, you're kind of given the solutions kind of throughout your issue. So, like, you know, that kind of triangulation or that joined up thinking is kind of needed, you know, to help like everyone figure out how to work together best to, you know, think more strategically about like the end user, the student, who, you know, is the customer basically in the education experience, and how to keep that, you know, stakeholder happy and successful. So I think that, and that kind of joined up thinking is also reflected by someone called Mitchell, I think it's Michelle Mitchell. She mentions as well just about thinking of the spaces as well and that kind of sensory overload. And I think Fiona Early mentioned that idea of the space itself, you know, being designed in a certain way to you know, help students cope. So, you know, students who have sensory issues, like, can we build in those quiet spaces throughout? And I think we've seen that here in Ireland. Campuses like DCU have great sensory spaces, both in like quiet areas and social spaces, and then like sensory kind of pods even in the library, so students can utilize them. So they've been kind of advocating those, which are working really well. And then Michelle Mitchell basically mentions as well about when students, say, even with or without mental health issues, but she said with, can self-isolate and then eventually withdraw, and then that's kind of a reflection of, you know, the institution really, that we've kind of allowed that to happen. So in terms of like what you were kind of saying, you know, none of us really have the answers, but at least supporting that kind of joined up thinking, you know, will certainly help institutions to figure out what, you know, those possible solutions can be, and start to, you know, eventually make that educational experience,
Absolutely.
more.
Well, I've just loaded again the slide from disability service providers, the things they refer. Obviously, you could have a whole workshop going through this and then using UDL to look at all the different ways that we can actually, reduce the tension there. Now, the other thing that, I'm advocating a triangular sort of communication between these three stakeholders, because that's immediately available. We can all do this in our campuses, fairly quickly just by breaking down the walls and engaging in those dialogues. But also students could be a fourth stakeholder in that dialogue, right? As we progress further, we could also have the students themselves as stakeholders. So we wouldn't even have to go second hand to disability service providers to understand what they're reporting, but actually engage them straight at, through committees and saying, what is it that you're feeling in the design of our campuses that is creating, exacerbating mental health issues? And that's maybe something further down the line that we have to look at and work towards as well.
Well, especially because it's kind of, I don't know if you found this through your research, but I think it's almost like there's the mental health of all students in a way that could be exacerbated by certain areas of assessment and certain parts of design. And then there's the students that have, a mental health condition or, a secondary, disability, and that can also affect it. That, it's almost, there's two aspects of it that, you could pick apart and look at from all of these different perspectives, including and especially with design. That's so important.
Absolutely. And I'd like to give you just a short example of some feedback that I've had in my practice before. Even when you look at assignment deadlines, which is has a huge impact, obviously, on mental health issues. We are afraid sometimes to touch that because we'll say, well, every assignment needs a deadline, otherwise you'd always be marking. But I'd worked with a department who had really thought this through and thought, what can we do using UDL to change that? And they'd come up with this notion that they had actually come up with it and come up to us as disability service providers and said, this could be a solution. And they tried it out and it worked really well. And it was the notion of embedding into your course outline days of grace period. So every course, every student had access to, let's say, 6 days, 7 days of grace periods. You could use it for one assignment. You could spread it out and use it for different assignments. You could not use it at all. So students were still accountable, but everyone had in their course assignments designed into it that little bit of freeway that they could manage in the way they wanted, depending on what was going on in their life. And that was enough. They reported back to say that the demand for remarks and extensions and things had just dropped massively, just by embedding that into the course outlines. So it can be fairly simple tips sometimes, and the solutions will come from UDL.
And actually, there's just one question from Anne Heelan. Anne, hi, how's it going? To what extent is societal fear of mental health an issue here, especially when faculty give way to medical views or over-rely on the views of psychiatrists? So...
Yeah, I think faculty do, but I think campuses generally do. I think, as I said, I'm almost shocked that sometimes you have people who can be huge UDL advocates, and they will talk about redesign when they talk about learning disabilities and they talk about medical conditions. And as soon as you talk about mental health, they sort of back away and say, oh, that's just too difficult, that's too sensitive. Yeah. So I think all of us, even in disability services, we have this sort of blockage. We have this fear that, yes, this design thinking goes a long way, but it has limits, and the limits are mental health. I would argue that it doesn't. It's exactly the same. And we can, change the environment and ease that tension by adopting a design thinking and make sure we don't fall back in a medical model approach.
Yeah, great. Okay.
Thank you so much.
Thank you very much.